Hello, hi, batch of class of 2024. This is Dr. Arbaz here. So, the topic of today's presentation is Maxillomandibular relationship, specifically centric relationship record. In the last lecture, if you recall, we had covered the orientation jaw relationship and the vertical jaw relationship. Including centric relationship, these three encompass the maxillomandibular relationship. So, today we'll be covering the horizontal jaw relationship, which is also known as centric relationship. So the learning outcomes for today's lecture are: you should be able to define and classify maxillomandibular relationships. Learning outcomes 2 to 4 have already been addressed in the previous presentation. Learning objective 5 is you should be able to define horizontal jaw relationship and centric relation. You should also be able to describe the methods to record centric relation. Now moving on to the once the correct vertical dimension orientation relationship has been determined and established, the necessary interocclusal distance of previous phase has been made, the jaw relationship in the horizontal plane can be commenced. Horizontal jaw relationship is, in simple meaning, is the recording of the bite registration. It is also known as centric relationship. It is a reproducible position which can be repeatedly arrived at and thus serves as a reliable guide to develop centric occlusion in artificial dentures. It is a starting point for arrangement of artificial teeth to develop maximum anticipation in complete dentures. Coming to the definition of centric relationship. It is a maxillomandibular relationship independent of tooth contact in which the condyles articulate in the anterior-superior position against the posterior slopes of articular eminence. In this position, the mandible is restricted to a purely rotatory movement. And from this unrestrained physiologic maxillomandibular relationship, the patient can make vertical, lateral, and protrusive movements. It is a clinically useful, repeatable reference point according to GPT-9. So, as I mentioned, centric relationship is a relationship of the condyle. That is, it is the anterosuperior relationship of the condyle against the posterior slopes of the articular eminence of the glenoid fossa. It is an unrestrained physiologic position in which the condyles purely rotate, that is, they exhibit a purely rotatory movement without any translation. So, coming to the importance of centric relationship, why it has so much importance in prosthodontics and in complete denture fabrication. Centric relationship is directly related to the proprioceptive impulses of the patient. In a dentulous patient, these impulses are generated by the periodontal ligament. However, in the edentulous patient, there are no periodontal ligaments, so there is no proprioception, mechanoreception, etc. In a edentulous patient, these what you call sensors are transferred to the temporomandibular joint. So the centric relationship act as this proprioceptive center, that is the TMJ in case of edentulous patients acts as a proprioceptive centers guiding the operator and in the patient and the patient to close in the ideal maxillomandibular relationship. Now, the salient features of centric relationship are: it is, as I mentioned before, it is a learnable, repeatable, and recordable position which remains constant throughout the life. It is a definitive entity, so it can be used as a reference point in establishing centric occlusion, that is, in during horizontal jaw relation. So, what are the various methods of retruding the mandible so that the mandible can be brought to the centric relation position, which is a bone-to-bone position, whereas centric occlusion is a tooth-to-tooth position. First is the physiologic method in which the patient is asked to repeatedly swallow. The second is patient is asked to take his tongue or fold his tip of the tongue backwards towards the junction of the hard and the soft palate. And the third is to guide the mandible to the centric relationship manually by keeping the index finger on the buccal flanges of the mandibular record base and the thumb over the chin and gently guiding the patient's mandible in a posterior and superior direction. The mandibular occlusism are gently tapped with fingers. This will automatically make the patient retrude the mandible, sort of a reflex action. When somebody claps their fingers in front of your face, suddenly your eyes shut. So in the same way, when you tap your fingers on the occlusal rims, suddenly the patient, by default or by an inherent mechanism, retrudes the mandible. Now, coming to the various methods for recording the centric, there are different methods. The first one is the interocclusal check record, or what we also know as recording jaw relation or maxillomandibular relationship using wax occlusal ribs. These can be recorded by applying pressure or without applying pressure while the patient is biting in centric relationship. Now advocated in 1923 that while recording centric relationship, pressure should not be applied. That is, the patient should not be guided uh, to close in centric by the operator because of the resiliency of the tissues under the record basis. Others like Schuyler, Payne, and Trapezzano advocated that some or slight pressure should be applied while the patient is closing in centric or while the operator is guiding the patient in centric. The next method of recording centric relationship is the functional method. In this, we have needle method, House method, which is also known as needle and House method. We have Patterson method, we have Mayer's method, etc. These are basically functional recording in which the patient is made to do certain movements of the mandible to record the horizontal jaw relationship. The third is a graphic method. As the name suggests, just like how we draw on a graph using a stencil, in the same way, using devices known as intraoral and extraoral tracers, the patient is made to do certain movements, excursive and lateral movements, and these movements are then recorded on a central bearing plate, which will be discussed later. So these are a regular record basis maxillary and mandibular occlusal rim. They are first established at the proper lip fullness, cheek fullness, at the proper level of the occlusal plane, proper incisive visibility, parallelism to the alar tragal line, etc. And then they are closed in centric relationship by guiding the patient's mandible, and then this recording is then sealed with the hot spatula and by making markings on the wax. This is not a new technique. This has been very old and most widely used technique. Some operators also prefer to make notches and grooves on the occlusal surface of the opposing rims, and then these grooves are filled with either softened wax or green stick molding compound, or a plaster index is also made. So now coming to the function of the chewing methods. These methods, as I mentioned, utilize the function movements of the jaws to record a centric relationship, such as protrusive and laterotrusive movements. The first method, as I mentioned, was the needle house method. In this method, basically, compound occlusal rims are used with four metal styli or studs are placed in the premolar and molar area of the maxillary occlusal rim. So instead of a wax rim, we have a compound rim in which four styli are placed, two on either side of the ridge, that is on the occlusal surface. Then the patient is asked to make movements in protrusive, retrusive, and laterotrusive directions. And these styli, which are in the compound maxillary occlusal rim, they make grooves or notches in the mandibular rim, which are diamond shaped. And the posteriormost point of this diamond pattern is considered as a centric relationship, and then patient is guided into the posteriormost part of this diamond pattern, and plaster or any type of mouth temperature or regular wax is used to seal the upper and lower rims. So this is how the occlusal rims will look. Of course, these rims were made out of compound, and four studs were advocated by Needle. Later, House advocated instead of studs to use four pointed sharp styli. So these styli were placed in the premolar and molar areas, and then the mandibular rim, which was made out of wax, and then the patient was asked to close in first in centric relation, and then he was guided to do protrusive, left lateral, right lateral excursive movements. This created a diamond, the posterior part of the diamond. This is the centric relationship, and the other parts are the, and this over here is the protrusive movement, and this is a left lateral, this is a right lateral movement. So these were, instead of studs, House advocated the use of styling. So that was the only difference between the needle method. The second was the Patterson method. The Patterson method used waxed occlusal rim. First, a trench or a trough was made along the length of the mandibular rim, something like a channel. And a 1:1 mix of plaster and carborundum paste was loaded or packed in this trench or trough in the mandibular rim. Then the patient was asked to generate mandibular movements, protrusive and excursive movements, and these continuous function movements generated a something like compensative curves in the occlusal surface of the mandibular occlusal rim. That is, the carborundum plaster mix was ground and it was pushed anteroposteriorly and mediolaterally in the form of compensating curves like curve of Spee, curve of Wilson, etc. So this was Patterson's Method. So here a trough was created. It was filled with the carborundum and plaster 1:1 mix. And the patient was asked to do all excursive movements, and this generated compensative curves in the plaster carborundum mix. So the disadvantage of the functional method is that they involve lateral and anteroposterior displacement of the record basis in relation to the basal tissues and supporting bone. So if the ridges are not tall, well rounded because of the excessive functional movement the patient generates, this may result in distortion of the movement of the record basis, resulting in inaccurate recording of the centric. Others, like Green, advocated the use of pumice and plaster in one of the rims and instructed the patient to grind the rims together. This was somewhat similar to Patterson method. Then another technique in which Mayer advocated the use of soft wax occlusal rim, which were then covered with tin foil and then were lubricated with oil, and the patient was asked to perform functional movements like swallowing, grinding, excursive, and protrusive movements, and this shaped the wax of the upper and lower rims, and then these were then packed outside with plaster to create an index, and then the rims were removed, and depending on the counter of these indexes, the teeth setting was done. So the next method or the group of methods is the graphic method. As I mentioned, graphic method mainly involves either an arrow point tracing, which is also known as Gothic arch tracing, or a pantograph, which is used to record the horizontal jaw relationship in a three-dimensional state. So coming to the intraoral tracers or Gothic arch tracers, which are a part of in Gothic arch tracers. So in this a central bearing device is attached to the occlusal rim. So here we can see that a central bearing device is attached to the maxillary central plate is attached to the maxillary occlusal rim, and a central bearing device is attached to the mandibular occlusal rim. It has a spring-loaded plunger or styli in the center of the central bearing plate, and this spring-loaded styli makes an arrow-shaped mark on the central bearing plate in the maxillary occlusal rim. Something like this. This is the assembly. One plate is attached to the maxilla, another plate with the styli is attached to the mandible, and it creates an arrow mark. So why? What is the significance of this arrow mark? The tip of the arrow is your centric relation. That is where the patient has to bite, and it is then sealed off with a hot instrument or with a stapler pins or with a green stick compound or anything. And the two sloping acute sides of the arrow represent the lateral tracing moments. Like for if we are seeing the patient's jaw from an inferior view, the sides of the arrows are created by the left lateral and the right lateral movement of the mandible. As you can see, this will generate the two sides of the arrow, and the straight bar of the arrow or the tail of the arrow is created by the protrusive movement of the mandible. So always the tip of the arrow will be pointing towards the throat of the patient. Now, so this is how internal tracer looks. The central bearing plate is attached to the upper maxillary occlusal rim, and the central bearing plate with the plunger or the styli is attached to the mandibular rim. And the patient is then asked to do protrusive left lateral and right lateral excursive movements, and this generates an arrow on the central bearing plate on the maxillary. This central plate or the sheet of metal is first coated with either with soot, that is by passing it over a flame or a candle, or it is coated with a thin layer of plaster or a thin layer of inlay wax. So this is how the central bearing plunger or styling makes the marking on the upper plate of the intraoral tracer, and this is the arrow pointing towards the throat of the patient. So now coming to the disadvantage of these tracers, intraoral tracer, are not visible during the procedure. That is, the operator cannot guide the patient. He only has to trust his judgment that a patient is able to understand his instructions. It may require multiple repeated attempts to create a proper ideal arrow of the centric relationship. The size of the tracing is sometimes very small. It is difficult to determine the apex of the tracing. Okay, now coming to the extraoral tracing devices, they are essentially similar to the intraoral tracing devices, but the central bearing plate assembly is outside the patient mouth. That is, it is attached by a fork to the exterior of the wax rims. It is protruding out of the patient's mouth. So also it has a large center bearing plate, so the tracing arrow is larger in size. It is easy to identify the apex of the tracing. So these are the center bearing plate with the plunger, center bearing plates which are attached first to the this this is the type of the intraoral tracer, and this on the right side is what we see the extraoral tracers, extraoral gothic arch tracers. So these forks or the prongs are attached to the upper and lower wax rims, and this is the center bearing plate, and this is the plunger or styli which makes a marking on the center bearing plate uh, of this assembly. Here we can see more clearly. So in this, the styli or the plunger is attached to the upper rim, and the central bearing plate is attached to the lower rim, and then it creates a arrow shaped marking. So what are the indications for these graphic methods? Whether it will be internal tracers or external tracers, they should be used, as I mentioned, in well-heeled, broad edentulous spaces or tall rounded ridges, because we need proper or absolute stability of the occlusal rims or the record bases during the tracing. So if there is some, first of all, records should be made with heat cured polymethyl methacrylate, which has a good fit and intimate contact with the basal seat area. The patient's inter arch space should be adequate, and patient needs to be trained with to close in centric. That is, patient should be habitual centric closer. Now, what is the contraindication? As I mentioned, if there are severely resolved ridges, the record basis will be unstable, and you will not get a proper tracing or failure to get a proper tracing. In case of excessively flabby and hyperplastic ridges, and when there is decreased vertical dimension of occlusion and vertical dimension at rest, in patients with existing temporomandibular joint arthropathy or disorder, or patient with restricted TMJ movements, so in such cases, we cannot use graphic tracing methods for recording the horizontal. Next in line is within the graphic method is the pantographic tracing. Now, pantographic tracing is defined as a graphic method of mandibular movement in three planes as registered by a styli on a recording table or a flag of a pantographic instrument. Tracings of the mandible movements are recorded on the plates in horizontal as well as the sagittal planes. So it is a three-dimensional tracer. It is the most accurate method available to record the centric relationship or the mandibular movements. In essential, a pantograph is derived from two Greek words which mean all, every, and to write. It is a mechanical device with two interconnecting pens or styli, so that when the movement of one pen or tracing with one pen is done, an identical image is produced with the second pen. So basically, that's what a pantograph is. This was used in olden days, probably in the early 19th century, to make copyright drawings. That is, to copy drawings identically. So this is how a pantograph looks. This is the first pen that creates a small heart-shaped sketch, and depending on the movements of this first pen, a second pen creates a identical, albeit larger, drawing of the heart-shaped sketch. So this is what essentially a pantograph does, which is attached to the by a device to the patient's jaws, and when the patient does the mandibular protrusive and laterotrusive movements, the same movements are copied on the pantographic plate or flag by the tracer or the tracing tape. So as a pantograph has six flags, that is four flags in the horizontal plane and two flags are in the sagittal plane. So here we see two flags in the anterior region. These are the styli that create the recording of the mandibular movements and the pinpointing of the centric relationship. These are two posterior flags that are with plungers to create the posterior movements, and we have two flags which are not visible in this picture on the side of the patient face, that is over the TMJ, which create the or copy the movements of the mandible in the sagittal plane. So, coming to the summary, centric relationship is a reproducible position which can be repeatedly arrived at, and this serves as a reliable guide to develop centric occlusion in artificial denture. That is, when the centric relationship records are taken, the jaw relationship is accomplished. The records are transferred to the articulator, mounted, and then the teeth setting can begin. So, but if you have recorded an accurate centric relationship, then the teeth setting that is done in this centric relationship is your centric occlusion. So, recording centric by using various methods of retruding the mandible is the starting point of arrangement of the artificial teeth to develop the maximum intercuspation in complete dentures. So, thank you all for a patient hearing. I'll see you again with another lecture.